acute hydrophilic-polymer nephropathy, and acute renal failure. Definition: hydrophilic coatings are used on intravascular devices to facilitate manipulation and to minimize complications such as vasospasms during a procedure and thrombosis after a procedure.
Armando Hasurungan Biology and Medicine videos. Please make sure to subscribe, join the forum and group for the latest videos. Please visit Facebook Armando Hasurungan. Now, in this video, we're going to look at acute renal failure, which is defined as a decrease in glomerular filtration rate. And I put reversible because in quotations because it may be reversible. But essentially, it's damage to the kidneys, which will cause a few problems, many problems actually. And so we'll look at these problems and some causes of acute renal failure. So here I'm just drawing the anatomy. Here we have the kidneys, the inferior vena cava, where the renal veins drain into. And then we have the ribs here. And here is the diaphragm, and here we have the aorta, which will supply the kidneys through the renal artery. And here we have the pelvis. And now the kidneys, as we know, produce urine, which will travel through the ureter and go to the bladder. And urine is stored in the bladder, and when needed, the bladder will contract and expel urine through the urethra. Now above the kidneys, we have glands known as adrenal glands, which are important because they produce some important hormones. Okay, now I want to talk about the main causes of acute renal failure. And there's three main ones. It can either be pre-renal, before the kidneys, intrarenal, within the kidneys, or post-renal, after the kidneys. So these are the main causes. But now we will focus on each one and look at these in a bit more detail. So pre-renal cause of acute renal failure can be due to a sudden or severe decrease in blood pressure, or it can be due to a flow obstruction to the kidneys, and this can be due to atherosclerosis or some form of ischemia, so stenosis. And then you have intrarenal cause. Now, intrarenal causes include direct damage to the kidneys itself, inflammation within the kidneys, a form of infection, drugs, as well as autoimmune diseases such as systemic lupus erythematosus. I hope I pronounced that right. And then the third one, the post-renal cause of acute renal failure, include mainly an obstruction of urine flow. So this can be due to a benign prostatic hyperplasia, kidney stones, as well as some form of bladder injury or tumor. Now we will mainly focus on intrarenal, which is the most common form of acute renal failure. So it's the most common cause. Now, before we look into that, we should just quickly brush over the anatomy. So here I'm drawing the right kidney, the ureter, the renal pelvis, the renal pyramids, which are within the renal medulla. And around this area are the functional units of the kidneys, which are called nephrons. So let's just zoom into one of these nephrons. So here I'm drawing one nephron. It has the head, which is the Bowman's capsule, and then we have this convoluted part called the proximal convoluted tubules, which then forms the loop of Henle, and then we have the distal convoluted tubules, and then the collecting duct. So let us briefly look at the function of the kidneys, of the nephrons. So in summary, an afferent arteriole will carry blood from the renal artery. This afferent arteriole will come down and it will be filtered in the glomerulus. And this occurs in the Bowman's capsule, the head of the nephron. A term to note is the glomerular filtration rate. And this is literally the rate at which the glomerulus filters the blood. When the blood is being filtered, filtrate is produced, and this is what will go through the nephron. The remaining blood will leave the glomerulus and exit out through the efferent arteriole. And this efferent arteriole will essentially make its way around the nephron as the vasa recta. The vasa recta, the vastus recta's role is to reabsorb things from the filtrate that is within the nephron. As well, the vasa recta will secrete things that it doesn't need. It will secrete things from the blood back into the nephron as filtrate. The vasa recta will then leave and head towards and join with other veins and form essentially the renal vein. The filtrate, which is inside the nephron, is what we pee out. It's our urine output. Okay, now let's just recap the three main causes of acute renal failure. We have pre-renal, intrarenal, and post-renal. We will mainly focus on intrarenal. Now, in intrarenal causes, there's actually four main types. We can have acute glomerular nephritis, and this is literally inflammation of the glomerulus. One of the main causes of acute glomerular nephritis is an autoimmune condition known as systemic lupus erythematosus. The second type of intrarenal cause of acute renal failure is acute tubular necrosis, and this is actually the main sort of sign we see in acute renal failure, which is death of cells within the nephron. And 50% of acute renal failure cases have this feature. And then we have acute interstitial nephritis, which is literally sort of inflammation of the interstitial space in the kidneys. And we see this mostly in allergic reactions as well as infection. Now, before we look at the fourth sort of type of intrarenal cause of acute renal failure, we have to understand that pre-renal, intrarenal, and post-renal causes are all connected. For example, a pre-renal and post-renal can cause an intrarenal problem. And so this leads to the fourth main type of intrarenal cause of acute renal failure, which is vascular. Okay, so we know that acute renal failure is characterized mainly by a decrease in the glomerular filtration rate, or GFR. So why do we have this characteristic of a decrease in GFR? Well, it can be basically caused by two main changes. The first is vascular change, where we see endothelial dysfunction, where we see vasoconstriction, particularly in the afferent arteriole, the arteriole coming into the nephron, as well as we can see an increase in adhesion of inflammatory cells, such as neutrophils. And this will cause and aggravate the problem. It will cause inflammation. The second change we see are tubular changes. So in tubular change, for example, here is within the tube of the nephron. The filtrate normally goes this way, and we now see cell loss. We see damaged cell, and this can be due to necrosis, or it can later cause apoptosis. So now these can form necrotic bodies, which will literally cause an obstruction in the tube, and as a result, the filtrate will backleak. The urine will backleak, and this can lead to other complications. So these are the two main changes that cause a decrease in GFR in intrarenal failure. Okay, so now just quickly going over the characteristics of acute renal failure. Functionally, we have, remember, a decrease in GFR, the filtration. This will lead to a decrease in urine output, and we will have, as a result of some problems in the tube, increase in nitrogenous waste in the blood, such as urea and creatinine. And this is what we can use to measure acute renal failure, sort of the severity. Structurally, in acute renal failure, we have cell death due to apoptosis or necrosis, as well as loss of adhesion to intrinsic renal cells. And this will, lead to obstruction and stuff like that. So that concludes the video on acute renal failure. I hope you enjoyed it. Thank you for watching.
Application in medicine. The patient underwent renal transplantation in which the renal artery was implanted into right external iliac artery between January and June 2013. Her serum creatinine level increased progressively over a 5-month period.
Welcome to part 2 of acute renal failure. Let's review a little bit here about what we were talking about. We were talking about Chem 7. We have the BUN, and we've got the creatinine. The BUN stands for the blood urea nitrogen. Remember, it's made in the liver. It is both filtered and reabsorbed, whereas the creatinine is the end product of muscle metabolism, and it is filtered and secreted. So let's look at our nephron once again. That's the loop of Henle, distal convoluted tubule, collecting duct, and you've got the toilet down here. Okay, and you've got the afferent and the efferent arterial. And remember what we said about the BUN. BUN is the blood urea nitrogen. It goes through and also gets reabsorbed. Okay, so that's BUN. And you've got the creatinine. Creatinine does not get reabsorbed, but instead goes out. Actually, a little bit gets secreted here. Okay, so if you've got acute renal failure, remember that the GFR, the glomerular filtration rate, is going to go down. So if that's the case, then your BUN is going to go up, just because of the fact that the glomerular filtration rate is lower, therefore not as much is being filtered, the BUN is going to go up. But because it's going by slower because the GFR is down, then more of it is going to be reabsorbed, and so it's going to go up by even more. That's opposed to the creatinine. Creatinine is going to go up. Why? Because the GFR is low. And the GFR is low because there's acute renal failure going on, and that means that creatinine is going to go up. But it's not going to go up any more than that because it's not being reabsorbed. And so what you see here is that the BUN goes up more than the creatinine does when you have a decrease in your GFR, just based on the fact that there's lower flow. So lower flow means higher BUN to creatinine ratio. Okay, so what would be a number here that we could associate with it? So normal would be, for instance, 15/1. So if the BUN over creatinine, if the BUN went up by more than that of the creatinine, we could say, for instance, that this would go to a 2 and a 30. Okay? So the BUN would go up to 30 and the creatinine would go up to 2. So you go up by, instead of having a 15-to-1 ratio, you would have more like, instead of even 30, it would even go up higher, it would go to 40. So a 40-to-2 ratio, which is the same as a 20-to-1 ratio. So here we would see the normal ratio is 15-to-1, and it would go up to 20-to-1, or in this case, 40/2. And that would be from a low flow state. Now, what would happen here if for some reason there was a shutdown? A different type of acute renal failure. Acute renal failure not because there's less flow coming to the glomerulus, but instead because the actual tubules which line the nephron, something we call renal failure, if they weren't working. Well, what would happen is that you would still get a slowdown here because these cells are not working, and the BUN would go up. But it would only go up for one reason, and that's because the GFR is low. You would not get reabsorption of this BUN. And so what you would have is, this would be more of a pre-renal. What I mean by that is that there is a reduction in the flow coming here, and because of that, you're getting the BUN increasing because of the low flow, and also the BUN is being reabsorbed because these cells are working. So that would be a pre-renal situation, or in a renal situation, these cells are not working. And so if these cells are not working, the flow is going to be low as a result of that, but you're not going to get BUN reabsorption. And so it's going to go up, instead of being 15-to-1, okay, it's going to go to 30/2, which is still the same 15-to-1 ratio, but they're both going up, but this is not going up more than that is, so it still holds the same ratio. So in a renal situation where there's a problem with the kidney itself, you hold and maintain that 15-to-1 ratio. But when there is a pre-renal state, in other words, there's not enough flow coming to the glomerulus, you're going to get a reabsorption of the BUN preferentially, and that's going to increase your BUN ratio to 20-to-1. Okay, so the bottom line here is that the BUN to creatinine ratio can kind of tell you what kind of renal failure you have. Is it pre-renal azotemia or is it renal azotemia? Pre-renal azotemia is where there's not enough blood coming to the kidney. Renal azotemia is where there's something wrong with the kidney itself. If it's 20-to-1 ratio, like this, you're thinking of pre-renal azotemia. If it's still 15-to-1 ratio, it's renal azotemia. Okay, another way of looking at that is just looking at sodium and water concentration. So let's go ahead and draw our glomerulus again, a little bigger this time. Here's the glomerulus, the proximal convoluted tubule, loop of Henle, and then out. Okay, so pretend you're a nephron, and you've got two different situations. You've got a situation where you have a pre-renal situation where there is not enough blood coming in to the kidney, and you've got a renal situation where there's a problem with the actual tubules that are supposed to be transporting fluids and reabsorbing. In a pre-renal situation, there's not enough blood coming in, and you have a reduction in your GFR. Well, the kidney thinks that there's not enough volume. And the way the kidney regulates volume is by reabsorbing sodium. So if there's not enough volume, all the kidney's going to do is just try to reabsorb more sodium. And so what's going to happen to your urine that's coming out? Do you think it's going to be high in sodium or low in sodium? Well, it's going to be very low in sodium in a pre-renal situation. And of course, as sodium goes up, guess what else comes with it? Water. And so are you going to have a lot of water in the filtrate, in the urine that's coming out? The answer is no. So you're going to be very low in sodium and very low in water. So that leaves a high concentration or a high osmolarity to the urine that's coming out.
Pros: polymer-coated interventional devices are used frequently and the diagnosis of polymer emboli is unlikely, since emboli usually lodge in the arterioles of downstream organs. Cons: the associated events range from non-detectable events to myocardial infarction, stroke, and death within days to months. Compute tomographic angiography reveals stenosis of the common iliac artery.
Hello, this is Andrew Wolf. In this video, I'm going to talk about acute renal failure. Now, I want to make a point that acute renal failure and acute kidney injury are often used sort of synonymously in clinical practice, but they are not synonyms. And I want to talk about how they are similar and how they are different. Now, acute renal failure can cause acute kidney injury, particularly there are various mechanisms to cause injury to the nephron, and also acute kidney injury can lead to acute renal failure, but they are not synonymous. Acute kidney injury it refers to injury to the cells inside the nephron, and acute renal failure refers to the failure for the kidney to perform its normal functions. For example, the kidney loses its ability to excrete wastes, and in the labs we see a increase in B1 and creatinine. Also, with acute renal failure, the kidney is no longer able to maintain a balance of electrolytes, and we see a increase in plasma potassium, which can be quite dangerous. And we can also see other derangements of electrolytes with decreases in plasma sodium concentration. And also we can see imbalances in pH as well. Now, I want to talk about three different causes for acute renal failure. The first is pre-renal, and this really refers to the kidneys failing because there is a problem with blood flow to the nephron. Now, the second cause is the opposite of that. It's renal failure that's caused by obstruction beyond the nephron. So this is called post-renal failure, and we end up with an obstruction in the ureters or the bladder, and this causes a disruption of the ability of the kidneys to perform its function acutely.
Issue applied in Ecuador. This renal lesion may be induced by hydrophilic-polymer emboli. We speculate that the stent in the iliac artery was the most likely source of the emboli, in light of the anatomical proximity to the anastomosis.
Acute kidney injury, or AKI, is when the kidney's not functioning at 100%, and that decrease in function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF, but AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types. Pre-renal AKI, meaning the cause of the kidney injury is coming before the kidneys, post-renal AKI, meaning after the kidneys, or intrarenal AKI, meaning within the kidneys. Now, the kidney's job is to regulate what's in the blood. So they might remove waste, or make sure electrolyte levels are steady, or regulate the overall amount of water, and even make hormones. The kidneys do a lot of stuff. Blood gets to the kidneys through the renal artery, into tiny clumps of arterioles called glomeruli, where it's initially filtered, with the filtrate, the stuff that gets filtered out, moving into the renal tubule. Sometimes fluid or electrolytes can move back from the filtrate into the blood, called reabsorption. And sometimes more fluid or electrolytes can move from the blood to the filtrate, called secretion. Along with fluid and electrolytes, though, waste-containing compounds can also be filtered, like urea and creatinine. Although some urea is actually reabsorbed back into the blood, whereas only a little bit of creatinine is reabsorbed. In fact, in the blood, the normal ratio of blood urea nitrogen, or BUN, to creatinine is between 5 and 20 to 1, meaning the blood carries 5 to 20 molecules of urea for every 1 molecule of creatinine. And this is a pretty good diagnostic for looking at kidney function. Ultimately, that filtrate is turned into urine and is excreted from the kidneys through the ureter into the bladder and peed away. Meanwhile, the filtered blood drains into the renal vein. Alright, so pre-renal kidney injury is due to a decreased blood flow into the kidneys. So you've got your total body fluid, with some fluid circulating in the plasma, as well as all the other intracellular and extracellular fluid. So a decreased blood flow could be due to an absolute loss of body fluid, where fluid actually leaves the body. And this could be caused by major hemorrhage or blood loss, vomiting, diarrhea, or with severe burns, where body fluid evaporates really fast without the protective skin. Decreased blood flow could also be due to a relative loss of fluid, where total body fluid stays the same. How can that happen, though? Well, one example of this is distributive shock, which is where the fluid moves from the blood vessels into the tissues, which keeps the total body fluid volume the same, but you have a relative decrease in blood volume. Another example is congestive heart failure, which is where the heart can't pump blood to the tissues. So a portion of that blood just pools in the venous side and isn't pumped to the body, meaning less blood is sent to the kidneys. Finally, the issue could be local to the renal artery itself. For example, it could become narrowed, as in renal artery stenosis, or blocked by an embolus, which is a blood clot from somewhere else in the body. Whatever the case, less blood's going to the kidneys, right? So less blood's going to the glomeruli, which means less blood's being filtered. So there's a decrease in the glomerular filtration rate, or GFR, which is how much blood, usually in milliliters, the kidneys filter through their glomeruli per minute. If less blood's being filtered, that means less urea and creatinine are filtered out, and more stays in the blood, which is called azotemia, high levels of nitrogen-containing compounds in the blood. This will also tend to cause oliguria, an abnormally low amount of urine production. Also, with less blood being filtered, the kidneys activate the renin-angiotensin-aldosterone system, which causes aldosterone release by the adrenal glands, which tells the kidneys to reabsorb sodium. When sodium gets reabsorbed, water gets reabsorbed as well. Water and sodium reabsorption is also tied to urea reabsorption. So in a pre-renal situation, urea gets reabsorbed, and so even more urea gets into the blood, resulting in a BUN to creatinine ratio of greater than 20 to 1. Now, looking at what gets excreted in the urine, more sodium and water being retained means that less is excreted. And the urine sodium is usually less than 20 milliequivalents per liter. And the fraction of sodium excreted to sodium filtered, or FeNA, is usually less than 1%. And finally, that urine is more concentrated, because remember, less water is excreted. So typically the urine's greater than 500 milliosmoles per kilogram, most of which is urea, which is why your pee smells so nitrogeny when you're dehydrated. Alright, so as a super quick recap, pre-renal acute kidney injury is where the kidneys aren't functioning at 100%, and this is due to less blood flowing into the kidneys. Now that you know all about pre-renal AKI, check out these other two videos on post-renal AKI and intra-renal AKI.
Conclusion. In conclusion, the current case highlights what we consider to be an under-recognized iatrogenic complication. Emboliform material may be present in patients who have undergone recent implantation of an intravascular device with a hydrophilic coating. Thank you.